Thank you for kind introduction. Good morning, everyone. Thank you so much. It's such an honor to have this opportunity to lecture at AAO. Today, I'd like to talk about the treatment of asymmetric malocclusion utilizing TED. In order to improve asymmetric growth, it may be possible to try an orthopedic or a functional appliance, or even muscle function training is before pubertal growth. But the outcome is not always consistent. If this asymmetric growth is become severe, and the disharmony between the face and occlusion increases, orthodontic surgeries may be required after growth. Fortunately, many asymmetry in clinical practice can be improved with orthodontic treatment only, and I'd like to focus on this orthodontic treatment modality today. First, asymmetric tooth movement through asymmetric extraction can be considered. Joe Lebellato had explained the treatment of asymmetric extraction for asymmetric patients, and a 3 premolar extraction could be the treatment of choice in order to simplify intra-arch and inter-arch mechanics in class 2 subdivision malocclusion. However, the advantage of asymmetric tooth movement using tooth extraction cannot be utilized for patients who have fair lip appearance with mild tooth clouding. Therefore, efforts have been made to obtain asymmetrical tooth movement without tooth extraction. Adesad introduced biomechanics for a variety of asymmetric tooth movement in 1995. Asymmetric tooth movement can be obtained using this method, but careful preparation for counteraction is required. Dr. Shuroff and Siegel reported unilateral class 2 elastics used for asymmetric mechanics may result in canting of the maxillary anterior occlusal plane. Unilateral application of the pushing force can also cause asymmetric overjet or severe midline discrepancy, as well as skewing of the maxillary and mandibular arches. Fortunately, as TED was introduced in orthodontic clinical practice, an asymmetric tooth movement is achieved with skeletal anchorage utilizing TED. Dr. Peng improved midline discrepancy by asymmetrically pulling teeth in class 3 patients with TED. Pulling teeth with using TED is the most commonly used method. Class 3 malocclusion is suitable for the use of pulling forces due to the mandibular asymmetry, midline discrepancy, and class 3 occlusion on the right side are shown, but she didn't have dissatisfaction of facial profile, and crowding was not severe. It was decided to install a TED on the buccal oblique ridge of the mandibular right molar area and to move the mandibular arch to the right. With the distalization of the mandibular right molars, the class 2 canine relationship become class 1 and is further improved to the mild class 2 relationship. A symmetrical occlusion was accomplished and the bracket were removed. Even though asymmetric class 3 malocclusion was caused by the mandibular overgrowth and unilateral TM joint resorption, symmetrical occlusion was restored by pulling the mandibular dentition to the right using TED. Like this, pulling teeth using TED is the most commonly used method. But let's consider a slightly different situation. Although the malocclusion is not severe, so this patient has class 2 subdivision malocclusion due to asymmetric mandible. The skeletal and dental relationship are favorable, and there is no need for extraction at all. In order to improve the class 2 subdivision, if you plan to maintain the right quadrant of the mandible in the same location and move the teeth of the other 3 quadrants posterior, so you can use the pulling force from posterior TED. Since the facial profile is good and the position of the maxillary dentition is favorable, it was decided to protract the lower right quadrant to achieve class 1 occlusion. So, how can we achieve a protraction movement of the posterior teeth? What kind of counter reaction will occur when TAD is installed in the interior and pulling force is applied to posterior teeth? Similar to the reaction of posterior teeth intrusion when retracting maxillary arch using TAD, when the dentition is pulled forward using TAD, is that the intrusion of anterior teeth appears. In the finite element study, the intrusion of anterior teeth was compounded with protraction of the mandibular arch. When posterior teeth are pulled forward unilaterally in TAD, the intrusion of anterior occurs on one side, causing asymmetric lowering of the anterior occlusal plane. Here is another patient showing a class 2 malocclusion on the left side. To improve the asymmetric occlusion, TAD were installed on both left and right side, and the lower teeth was pulled to the right. You can see improvement of midline, but the counteraction of occlusal plane lowering in vertical plane occurred due to intrusion of left anterior teeth. The asymmetric anterior posterior problem turned into an asymmetric vertical problem. To prevent this side effect, I recommend using a pushing force instead of a pulling force from the TAD. Instead of manufacturing a whole new product, I prefer utilizing already existing products to develop a new treatment modality. This way, new techniques can be applied more simply at a low cost. To apply pushing force, a combination of TAD with a hole in the head, segmented arch wire, and open coil spring are used, and I named this TAD-supported pushing spring or lead spring simply. To treat this patient with class 2 subdivision malocclusion, I decided to use TAD-supported pushing force for medularization of mandibular right quadrant. Overjet was increased after initial leveling, and the mandibular anterior teeth and canine were pushed forward using a TAD-supported open coil spring. After improving the midline and canine relationship, the premolars and molars were moved mesially. Good occlusion was formed by mesial movement of the lower right quadrant. The mandibular midline was corrected, and a good class 1 occlusal relationship was achieved without using intermaxillary elastics. Even after 2 years since debonding, good class 1 occlusion and symmetry were well maintained. In many cases, the protraction is more useful than retraction in the treatment of class 2 malocclusion. Let's take a closer look at the lead spring mechanics in a class 2 subdivision example. Due to the nature of class 2 occlusion, its overjet increases after leveling. First, the TAD with the whole head type, pole type head, is installed in the posterior area of the mandible. During the installation, the direction of the hole is adjusted horizontally so that the wire can be inserted into the TAD like a molar tube. Separately from the main arch wire, an accessory wire of the 6 anterior teeth is made with 0.18-inch stainless segmental wire. And a step on the band is made on the wire to go through into the hole of the TAD. And an open coil spring is placed to give pushing force. By pushing the canine and anterior teeth forward and laterally with this technique, class 1 canine relationship is easily restored without intrusion of the anterior teeth, and the midline is well improved as well. 01-ray stainless steel wire is used for both the main and sectional arch wire. Using the combination of TAD and segmented arch wire, the force of the open coil spring can be adjusted 3-dimensionally. Also, since it is used together with the main arch wire, the high stability can be maintained during the movement of the anterior teeth. A TED with a hole in its head is required to obtain a TED-supported fusing force. A lot of manufacturers produce this type of head. As the 6 anterior teeth moved anteriorly by the open coil spring, class 1 canine relationship was restored, and the midline was also coincided. After preparing anchorage with an open coil spring to prevent retracting back the canines, the premolars were protracted with elastomeric power chain. The protraction of premolars and molars slide along the main arch wire, which is usually 1/9 by 0.5 stainless steel rectangular wire. The next step is the protraction of the molars. If the TED interferes with the movement of the posterior teeth, the TED should be repositioned anteriorly. At this time, it can be moved just behind the premolar. Alternatively, it may be installed between the root of premolars that have already been moved to the desired position. After using the open coil spring to firmly hold the canine in the repositioned TED, the posterior teeth are moved forward. Following the protraction of the posterior teeth accomplished, the class 1 occlusal relationship was achieved. By adjusting the amount of open coil spring, the position of the canine and anterior teeth can be adjusted forward or backward at any time. While maintaining the vertical stability of the mandibular anterior teeth, the posterior teeth can be moved forward effectively. By using this pushing force, the symmetry can be restored with the horizontal as well as vertical stability. While the tooth move to form symmetry, the main arch wire and TED-supported segmented arch wires work together to maintain the stability of the entire arch. Here is another class 2 subdivision malocclusion patient. A dentition on the mandibular right side was positioned far distal to the maxillary arch, is causing deviation of the mandibular midline with large overjet. TED and open coil spring were used to push the lower right teeth forward and left. By using one TED, the midline was easily improved and a symmetrical class 1 occlusion was formed. After 2 years of retention, the class 1 occlusion was well maintained. Class 2 skeletal features still remained, but patient was still in fair harmony. The skeletal and dental relationship still remained stable. TED-supported pushing force is very effective to correct the midline and restore class 1 molar relationship without vertical and transversal side effect. This patient had 6 premolars that were congenitally missing, which caused the collapsing of lower incisors to right side and deviation of the lower midline. In the mandible, 1 premolar was missing on the left side, and 2 premolars were missing on right side. So the mandibular anterior teeth shifted to the right side. On the left side, is moving the posterior teeth to the extraction space of the primary molars could close the premolar missing space and improve the position of the anterior teeth at the same time. On the right side, the canine had to move mesially while moving the posterior teeth at the same direction. Therefore, it was decided to improve the midline by using a TED-supported open coil spring and obtain a symmetrical position of the molar. To improve the mandibular midline to the left side and close this congenitally missing space, the mandibular left deciduous second molar were extracted. Mandibular right, the deciduous second molar were exfoliated. A TED with a hole on its head was installed on the right side of the lower jaw. the lower anterior teeth were pushed to the left with the TED-supported open coil spring, and the premolar space on the lower left side was closed by the protraction of the left posterior teeth. Lower midline is improved, and left premolar space was closed easily. Then the symmetry of the molars was restored while adjusting the implant space for moving the mandibular right molar mesially. Using one TED and pushing force, the symmetry of the mandibular arch was restored. TED-supported pushing force can be effectively used when the anterior and posterior teeth need to be moved in one direction. Out of 6 congenital missing teeth, the spaces for 4 missing teeth was closed, and 2 implant spaces were left on the right side. With protraction of the mandibular right teeth, teeth axis and midline of the anterior teeth improved. The midline and class 1 occlusion was stable and well maintained at 1-year retention check. The next patient to look at together showed class 3 occlusion and midline displacement is due to asymmetry overgrowth of the mandible. Because of this, there was a tendency of crossbite on the right side, and the primary molars retained due to the congenital missing of the lower left second premolar. It was decided to retain the primary molars as long as possible and to treat using the extraction space of the mandibular third molars. TED was installed on both sides of the mandible, and the midline was improved by using a pushing force as well as a pulling force. Asymmetric TED mechanics was applied. A TED-supported pushing force system was formed on the right side, and a TED was installed under the root of primary molars on the left side for use of a pulling force. Asymmetric occlusion was improved by appropriately using the asymmetrical force, which finally achieved a good class 1 occlusion at the end. While the mandibular dentition moved to the left, a proper teeth axis was formed as parallel to each other. This patient also had an asymmetrical growth of the mandible, causing the upper and lower arches to deviate with each other and forming an asymmetrical occlusion. Midline deviation and right side crossbite were shown as corresponding to the asymmetry of the mandible, along with the deep curve of Spee. There was mild protrusion of the lip and incisors, and the maxillary posterior teeth axis was tilted due to a posterior clouding. In order to adjust the arch asymmetrically, the premolars were extracted in asymmetrical pattern. The midline of the anterior teeth was attempted to be coincided by installing a lead spring on the right side and pushing the anterior teeth to the left. The mesial movement of the mandibular right canine was followed by the increment of mesial movement of the posterior teeth, which improved the crossbite at the same time by constricting the right side of mandibular arch. TED were additionally installed on the right side of the maxilla and the left side of the mandible to help the asymmetric tooth movement of the arch. As the midline improved, the right canine formed class 1 relationship, and since the lead spring firmly anchored the canine, the posterior teeth are able to move forward easily and stably. The lower right posterior teeth moving forward improved the crossbite. After the asymmetric extraction of the mandibular teeth, a lead spring was installed on the right side, and the midline was repositioned by pushing the mandibular arch to the left. The lead spring played a critical role in adjusting the shape and position of the arch. The treatment is in progress, and the treatment result is expected to achieve a good symmetry and class 1 occlusion relationship. TED-supported pushing force can also be used to improve maxillary anterior asymmetry. The midline was displaced to the left as the maxillary lateral incisor was placed lingually with close by, and the canine and posterior teeth were showing class 2 occlusion. Maxillary premolars were extracted, and mini-tube were used to improve lateral incisor close by. An open coil spring was used, but distal movement of the canine was more definite than midline improvement. The midline improvement was not clear even after improvement of lateral incisor close by. Space closing was in progress, but the maxillary midline was still shifted to the left. However, retracting the maxillary arches to the left side to coincide with the maxillary midline was challenging because there was not much overjet remaining to allow for the retraction of the entire anterior teeth. Since the overjet was small, the midline was improved by pushing the upper anterior teeth with lead spring. The midline was finally coincided. The treatment was completed after moving the posterior teeth mesially. In this case of extraction of only maxillary premolars, it was important to form enough overjet for long-term retention. Enough overjet was easily formed using the pushing force of the lead spring, and the treatment was completed. Proper anterior interdental relationship and its good lip profile was shown, and root parallelism was well maintained. TED-supported pushing force can be used not only for treatment to improve on asymmetric occlusion symmetrically, but also when an asymmetric occlusion is needed to be formed intentionally. This male student had an central incisor crown fracture, and he was referred to me because prosthetic fabrication was difficult due to the subgingival fracture margin. We can help with the preparation for a prosthetic fabrication by expanding the space and extruding the root, or we can close the space after extraction. I decided to extract the central incisor and move the upper right teeth forward to form a class 2 occlusion with an asymmetric molar position. Dr. Zhang reported a case report with an asymmetric incisor extraction pattern using TED. The right central incisor had to be extracted, and then he installed a TED on the right and pulling the opposite anterior teeth to the right. Inevitably, the intrusion of the anterior teeth was accompanied with this mechanics, and it was shown in the superimposition. To avoid such intrusion effect for my patient, I used the TED-supported lead spring instead of pulling pulse. To improve the aesthetics of the entire teeth, the lateral incisor was forced to push it anteriorly. Then the canine was moved anteriorly solely as it has a long stubborn root. The pushing force was very effective for the major movement of the canine. All remaining teeth on the right are moved mesially afterward. After moving the lateral incisor mesially using a lead spring, the canine was subsequently moved mesial to replace the lateral incisor. After the canine moved, the premolars and molars were shifted mesially as well. Instead of using pulling force from left side, The pushing force from the right side was used to reduce the possibility of anterior teeth intrusion. The upper right teeth was protracted by one tooth size to form a class 2 canine and molar relationship. Here is the comparison of before and after treatment. The major movement of the maxillary teeth on the right side is resulted in an intentional asymmetry of the posterior teeth position. The posterior teeth was sufficiently moved forward to close the extraction space of the maxillary central incisor without causing a significant change in the anterior-posterior position of the maxillary anterior teeth. Even after 2 years of retention, the occlusion was stable and well maintained, even though he didn't use removable retainer at all. The tooth axis and position is formed after treatment. It was also well maintained. TAD-supported pushing force can be effectively used in case where an asymmetrical occlusion must be intentionally formed due to unilateral tooth extraction. Let's summarize today's lecture. To improve asymmetrical occlusion, if we move patient teeth anterior, posterior differently on left and right side, unwanted vertical and transverse tooth movement may appear. So, controlled asymmetric biomechanics are required. Controlled asymmetric biomechanics can be applied by the controlled pushing force using TAD with hole, guided sectional arch wire, and night-tie open coil spring. Vertical and transverse tooth movement can be controlled more efficiently by this combination, so-called lead spring. Thank you for your attention.